Okay, so our different types of insulin, you've probably seen this chart 800 times. So the ones that we most commonly use in hospital are gonna be our rapid acting and our long acting, so these Lispro and Lantus. What are some things you really need to remember if you're gonna give a patient Lispro? Do they have food at the bedside? Do they get snacks that you can go get them? Because our risk for that one is hypoglycemia. It's gonna start to work within 5 to 10 minutes, and it's gonna peak within 30 to 90. Do y'all know what is the only kind of insulin that you can give IV? Regular, okay. High potassium is urgent, we need to get going if we've got a patient with a really high potassium, so you might have to give somebody, 10 units of regular insulin IV push. Have y'all heard of like the potassium protocol? How, potassium follows into the cell. Make sure that you get somebody to verify that with you, and don't ever pull up your insulin with a 10 cc syringe. Because I'm sure y'all can see where this is going. I've had to go to calls where I've heard of nurses pulling up 10 units of insulin, and it was really 10 mLs of insulin. And thankfully, the person that they had verifying them caught it, but could you imagine if they didn't? The patient would be deceased. So now the problem's not only, like the potassium's not an issue anymore because they passed away. So it seems silly that we have to get a witness for some of these things, but like, it's because somebody else has made a huge mistake. So just slow down and use all your safety measures. With our Lantus, you have to have a doctor's order to hold it. So if you feel like you've got a patient and their blood sugar is 80, they probably don't need that 50 units of Lantus. Don't just go give it. That is what happened to me when I was a new grad. Was the nurse before me got real busy during day shift, and that patient's blood sugar was 80, and then they got like 45 units of Lantus. So then when I came on to shift, and I went into the room and the patient was unresponsive, I was like, oh no, what do I do with this? Checked their blood sugar and it was 15. And they had gotten all their Lantus with their little blood sugar of 80. So slow down and think before we give these medications, and think about what could go wrong here. On that same note, we want to educate our patients on hypoglycemia. So a great way to remember it is with the mnemonic tiger. So our T is for tachycardia, I for irritability, R for restlessness, E for excess hunger, and D for diaphoresis. What medication do we give patients commonly for their heart that might mask some of these symptoms?
Beta blockers.
Yes. So we have a patient that is a diabetic and they're getting metoprolol. What do we want to educate them on?
Check their sugar often.
Check their sugar often. That they might not feel these traditional symptoms of hypoglycemia whenever they are administering their insulin. They also need to eat consistent meals at consistent times. They don't need to skip any meals after taking their insulin, and they need to carry snacks, candy, or glucose tablets with them. A lot of our patients have not got any experience in healthcare, so we've got to teach them how to give themselves injections, and this starts like when they get admitted for DK. So I have a lot of patients that they would go into DK at like 45 years old, and they have never had any issues. They are new onset diabetes, and they don't know how to give themselves an injection. So as soon as they come off the insulin drip, we're starting education as the nursing staff. You kind of have to take this on yourself and say, I'm gonna teach this patient while I'm in here. I'm not just gonna come do this task and move on to the next one, because you can really make a difference in this patient's outcome by taking the time to sit down and educate them on how to properly administer their insulin. When they need to check their blood sugar, the things that they need to look out for with the different types of insulin. NCLEX also likes to test on how do you pull up regular insulin and NPH. Just remember it's clear before cloudy. So your regular insulin is clear and your NPH is cloudy. So clear before cloudy. Those are the only two. I'm pretty sure those are the only two that can go in the same syringe. We also want to educate our patients on the long-term effects of unmanaged diabetes. My husband's grandmother, we call her Granny. She has had diabetes. She would tell you she was not diabetic, but she sure was. And when her blood sugar would stay up there in like the 300s, she would have the classic signs of diabetes and the damage associated. So she would be like, oh, I really can't see very good. I don't know what it is. Well, as soon as she got on some insulin and her blood sugar was managed, all of a sudden Grammy can see again. So, but our patients don't know that. You've got to educate them on, this is gonna damage your kidneys over time, this is gonna damage your vasculature, can damage your eyes. They don't think about that, they think it's just your blood sugar. They don't think about that there's this whole other cascade of events that can happen with unmanaged diabetes. So we also want to educate our families. So a medication that these patients are going to start is also glucagon. They're going to have glucagon injections IM for rescue. So we have to educate the families on how to administer glucagon and how they can store their insulin. So unopened insulin, I think I mixed this up. Open insulin goes in the fridge. Unopened insulin can be stored at room temperature. We also have to educate these patients about their pumps, like their insulin pumps and their CGMs. Grammy started putting her CGM monitor in the kitchen because it was beeping too much. She does not know what the low alarm sounds like, but she does know the high alarm, and she started storing it in the kitchen so they wouldn't wake her up at night. So then I got to talk to Grammy about, we don't need your blood sugar monitor in the kitchen. If your blood sugar is measuring high, that means you need insulin, not a snack, and not to go back to sleep. So you will be a nurse at work, and you will also be a nurse at home. So for our levothyroxine, you also see it as Synthroid. This is our thyroid hormone replacement. We use it in hypothyroidism. We use it IV in myxedema coma. We also give this to patients post-thyroidectomy and for thyroid cancer suppression. Main things that we need to know about that is it's going to normalize their metabolism and improve energy. So all these symptoms for hypothyroidism on this picture, think about it doing the opposite. So these patients are going to report improved energy, it's going to regulate their heart rate and their temperature, and support normal growth and development. As far as our patient education for Synthroid, you will see so many patients on Synthroid, so it's important to know this. Take it in the morning on an empty stomach at least 30 to 60 minutes before breakfast. You also want to separate your levothyroxine from any other calcium supplements, iron, antacids, or multivitamins by at least 4 hours. And that's a big one for antacids in general, is that it has to be 4 hours away from any other medication administration because it's going to bind to the drug and reduce the efficacy. These patients are going to get a TSH level drawn every 6 to 8 weeks until it's stable, and we have to educate them that this therapy is usually lifelong. They need to watch for symptoms of drug-induced hyperthyroidism. So we're think about all the effects that the drug does, and think about it doing too much. So palpitations, tachycardia, heat intolerance, weight loss, insomnia, and tremors. The patients should also not switch between brands without talking to their doctor first. So we have to educate them on that, because depending on, we have patients all the time that report issues with their insurance and getting different brands of medication. We have to educate them that they have to take that one brand and not to switch back and forth. IV administration is preferred for our myxedema coma patients and patients who cannot tolerate PO acutely. They always told us in nursing school that Synthroid was not to be pushed IV, and then I got out and practiced, and we do have it. You just have to push it very slowly. For our steroids, these are going to be our own. So prednisone, methylprednisone, dexamethasone, and hydrocortisone. They are going to suppress our immune and inflammatory response, decrease prostaglandin and cytokine production, and suppress the HPA axis. These are going to reduce inflammation, decrease our autoimmune activity, prevent transplant rejection, and reduce cerebral edema. Our major adverse effects of these are very dependent on the dose and duration. It's going to be hyperglycemia, infection risk. It might mask a fever because you see it's got the decreased autoimmune activity, cause GI irritation, fluid retention, hypokalemia, hypertension, and mood changes. So it's going to mimic this. The symptoms of the side effects of this are going to mimic this picture. This is attached. You'll have patients that come into the hospital that they're managed outpatient for their diabetes on just metformin or just PO meds, and then we'll bring them to the hospital and put them on steroids, and then they've gotta be on insulin. Sometimes they will get very panicky that they're gonna be on insulin therapy lifelong, and it's usually just while we've got them on steroids. So make sure you talk to your patients about these concerns and educate them that this is just part of the medication. So long-term use of our steroids can lead to an adrenal crisis, especially if these are stopped abruptly. You have to taper off steroids. You can't just stop them. These patients might experience some psychiatric effects like insomnia and mood swings, especially at high doses. It also decreases calcium absorption, so we're increasing our fracture development. Can y'all think of any patient populations that might be on steroids pretty often?
Addison's disease.
Addison's. Think about like our COPD patients. So if you've got a COPD patient that's on long-term steroid treatment, they're gonna be at a much higher risk for osteoporosis and fractures. And then for children, it suppresses growth and development. The things that we need to teach these patients as well is you wanna take your steroids with food, take it in the morning to monitor their blood pressure and their glucose, and do not stop suddenly, and report black tarry stools or severe weakness. Another way to remember the side effects is 7 S's, so swollen, sepsis, because they've got a higher risk for infection, so if they need to report a low-grade fever, even if it's as low as like 100, sugar for the hyperglycemia that we expect with these medications, skinny for, think about skinny muscles and bones causing increased risk for osteoporosis and fractures. 5 is sight. When I was researching all this to make this presentation for y'all, I saw that sight was a common thing that the NCLEX was testing on that I didn't know about. So sight, so it puts these patients at higher risk for cataracts, so you want to refer them to optometry. To prevent crisis, we want to do our 6S, which is slowly taper the meds off. And if these patients are in periods of stress or surgery, you might have to increase their dose. Now we'll get into the anti-epileptics. There's lots of mechanism of action for the anti-epileptic section, but the main things that you guys would need to know is the therapeutic levels that it has one, adverse effects that you need to look out for, and the nursing considerations. So therapeutic level for phenytoin is 10 to 20 micrograms per milliliter. The adverse effects that we're looking for are gingival hyperplasia. So we want to teach these patients about good oral care, because gingival hyperplasia is where their gums just keep growing and growing. They can help prevent this with good oral care. Nystagmus, ataxia, sedation, Stevens-Johnson syndrome risk. Pretty much across the board for all the anti-epileptics, there's a risk for Stevens-Johnson syndrome. And when you administer IV, there's a risk for hypotension. So we're gonna be checking our serum phenytoin levels, check a CBC, provide our oral hygiene education, administer with IV slowly, and do not mix with IV dextrose, and don't stop abruptly. Because, why wouldn't you wanna stop a seizure medication abruptly? Because it can cause seizures. Do y'all know some signs that need to be watched out for with Stevens-Johnson syndrome? Any sort of new rash. So if the patient starts getting a new rash, they need to report that to their PCP. And with a fever or severe bruising. For pretty much all of our anti-epileptics, they also need to adhere to a very strict timeline on the meds. So if they're gonna take it at 8 a.m., they need to take it at 8 a.m. every day, and make sure to not miss any doses. Valproic acid is also called Depakote. This is going to increase our GABA levels and suppress abnormal brain activity. It prevents many seizure types, but the major adverse effects are going to be GI upset, weight gain, and tremor. So think about, like, our patients, they don't want to gain weight, so when we put them on this medication and weight gain is a side effect, that's a big red flag that they might not adhere to their therapy. So we've got to educate them on the importance of this medication and how it's going to prevent their seizures. And you also want to report those concerns to their provider as well, and see if there might be a different medication that they can use. For these, we're going to watch out for pancreatitis and thrombocytopenia, And we'll monitor these patients' liver function tests, their platelets, and assess their abdominal pain. We also wanna avoid these in pregnancy, but even if these patients, if they get pregnant, they do not wanna just stop this medication immediately. They wanna talk to their provider before they just stop cold turkey. So you can remember this medication side effects with the mnemonic for the name. So vomiting, alopecia, liver toxicity, pancreatitis, rash, obesity, ammonia, teratogenic, and enzyme interactions. Our next one is Tegretol. It's a sodium channel blocker. This one more so prevents our focal seizures. It is used for trigeminal neuralgia and bipolar disorder. The major adverse effects can be drowsiness and dizziness. We're also looking out for agranulocytosis, aplastic anemia, hyponatremia, and again, Stevens-Johnson syndromes. We are gonna be looking at their CBC, their sodium levels, watch for any signs of infection, and if they get a rash, we need to stop the drug. This is one that we avoid grapefruit juice with as well. We do wanna take this medication with food, which is not grapefruit juice, and report any signs of infection immediately. Lamotrigine is another sodium channel blocker, but it's gonna decrease glutamate release. And it is another one that we use for bipolar depression as well. Again, the concern is SJS, as with all of our anti-epileptics. We're gonna be looking for a rash, fever, mucosal lesions, or severe bruising. This medication, we kind of titrate it, so we start low and then we titrate slowly. But if they do develop a serious rash, we're not going to restart it. But again, we're not gonna stop this abruptly. The most serious risk, like I said, was SJS, but especially that's gonna be in the first 2 to 8 weeks of treatment, especially if the dose is raised too quickly. The most common one that we administer is Keppra, so levetiracetam. The major adverse effects are fatigue, dizziness, and behavioral changes. Some patients report something called Keppra rage. They do need to report this to their provider. It's a sudden, intense irritability with irrational anger, outbursts of fury. This can really affect our patient's quality of life. So we wanna educate them that this is a side effect and that if they start experiencing this, they might need to take a different medication. So we need to tell them to report that to their PCP, not just kinda, wear through it. We wanna monitor their mood irritability. This does have fewer drug interactions than any of the other anti-epileptics, and it has no routine monitoring required, so it's a little easier for our patients to adhere to. Our key takeaways with the entire class of anti-epileptics is to never stop it abruptly and taper only under provider supervision. If they get a rash, they gotta stop the medication. Know our lab monitoring, that's another thing that NCLEX likes to test on, is if you have a medication and there's a therapeutic range associated with it, it's a good idea to know what the therapeutic range is and what it looks like if that medication gets to a toxicity level. And know which ones are teratogenic. But again, you don't wanna stop these abruptly even if they are pregnant. Our next section is mental health, and then after mental health, we'll get into the antibiotic part. Okay. We've got 2 different generations of antipsychotics. We've got typical and atypical. So typical is gonna be our Haldol, and atypical will be our Risperidone and our Seroquel. The complications of this is extrapyramidal side effects, we're just gonna call them EPS, tardive dyskinesia, and neuroleptic malignant syndrome. You will get these notes. I'm about to say a lot of words that are not on this slide, but you will receive this. Our antipsychotics are used to treat schizophrenia and schizoaffective disorders by decreasing symptoms like hallucinations, delusions, and disorganized thinking. So when we think about Haldol, and we think about both of these classes of meds, we're gonna think about dopamine. So Haldol is going to block dopamine. It has a very profound dopamine blockade effect. Dopamine is related to movement. So that is why these carry a really high risk for extrapyramidal symptoms. Do y'all know what extrapyramidal symptoms is gonna look like? Okay, it's like the twitching, the odd mouth movements, It's hard to get patients to stay on these medications when they look up the side effects and they see that they're gonna develop some of these issues. So we have to talk to them about why these are important and how it can really impact their life in a positive way to hopefully get them to stay on it. Our atypical antipsychotics are gonna block dopamine, but they're also gonna block serotonin as well. And that helps reduce the risk of them getting severe movement disorders. So our atypicals are a little bit easier for patients to stay compliant to. So our EPS happens because the dopamine blockade, like I said, controls movement. So when dopamine drops, patients can also develop rigidity, tremors, dystonia, or akathisia. Akathisia was a new word for me. I hadn't heard that one since nursing school. But that is like an intense internal restless. So that can also, if we've already got a suicidal patient, that can heighten their suicide risk. So you also have to educate your patients on that as well. Tardive dyskinesia differs from EPS in that it's a late, potentially irreversible complication from long-term dopamine blockade. The brain becomes hypersensitive to dopamine, leading to involuntary facial or tongue movements. So EPS is reversible, and tardive dyskinesia is irreversible. The most severe complication from these meds is going to be neuroleptic malignant syndrome, and that occurs due to this profound dopamine blockade in the hypothalamus, and it's going to affect their muscle regulation. When you see these patients, you're going to see a high fever, severe rigidity, autonomic instability, so their vitals are going to be all over the place, and altered mental status. So that's kind of the emergency associated with these drugs. For our antidepressants versus our anxiety meds, we've got two classes that are going to be most commonly used for antidepressants. It's going to be SSRIs and SNRIs. So these are going to work by upping our serotonin or upping our serotonin and our norepinephrine. We have to educate these patients a lot that it's a delayed onset. So they're going to start taking this, you're going to have your depressed patient, and they're going to report low energy and hopelessness. So we're going to put the patient on an SSRI like sertraline or fluoxetine, and they think the next day their mood's going to improve and they're not going to be so hopeless anymore. But that's not what's going to happen. Their energy is going to improve before their mood. So if we've got a patient that's depressed and they're suicidal and they've been thinking they want to kill themselves, but they don't have the energy to do it, now we've put them on a Zoloft, and now they have the energy to act on those hopeless thoughts. So our biggest risk with our SSRIs is going to be an increased suicide risk in those first 2 to 6 weeks. So that is with the delayed onset. So you're, in the commercials, when you hear the commercial for the antidepressant, it says increased suicide risk, that's the period, the first 2 to 6 weeks, when they have the energy to act on their hopeless thoughts. You might see this described as their energy improved before their mood. With these medications, your SSRIs and SNRIs, you're looking for serotonin syndrome. That's going to look like agitation, hyperreflexia, clonus, and fever. You don't want to mix these medications with an herbal supplement like St. John's wort. That was like drilled into us when I was in nursing school. St. John's wort is teratogenic, so if you combine it with an SSRI, you have a high risk for serotonin syndrome. If you put a bipolar patient on just an antidepressant, you can throw them into a manic episode. I think I have a slide on that later down, so we'll talk about them more in a minute. For anxiety medications, we're looking at our benzos. These are best for short-term use and they have a risk for dependency. Do you all remember what the reversal agent for benzos is?
Flumazenil.
Flumazenil or Romazicon. These patients, we're going to educate them on taking too much, on what that looks like. We are also going to educate them about Buspar and how it works differently than our benzos. So Buspar does not have a PRN effect. It works in the same timeline as like our SSRIs. So again, our anxious patients are going to take this and they think their anxiety is going to be cured like tomorrow. But it's going to take 2 to 6 weeks for it to really kick in. So, with bipolar disorder, you have kind of a switching between manic and depressive episodes. If we put these patients on just an SSRI, we can worsen their bipolar disorder. So when you're in the hospital, especially if you're gonna go work in like ICU or ED, where you're taking care of these patients when they're in a manic crisis, You wanna kinda watch what is your provider prescribing, cause if they're just prescribing at Zoloft, we're gonna make this patient be pushed all the way into mania, and then we have fixed nothing. These patients also need a mood stabilizer. So this is where we look at like valproate, which is also an anti-epileptic. What was our key takeaway with our anti-epileptic class? What's the highest risk? Stevens-Johnson syndrome. So we're gonna look at Depakote and lithium as our mood stabilizer. Lithium has a pretty narrow therapeutic range. It's gonna be 0.8 to 1.2. So we have to really monitor their serum levels, their renal function, and their hydration status and sodium balance closely. If our patients on lithium get dehydrated, they can increase their lithium levels really quickly and lead to toxicity. Okay. This is like the biggest section. This is the worst section. So just stay with me. Penicillin. These are gonna be all of our illins. Amoxicillin, ampicillin, and zosyn. These are gonna inhibit bacterial wall synthesis and cause the bacteria to burst. The main things for your NCLEX that you need to know with your anti-infectives is like, what is our nursing consideration? So with our penicillins, it's that there's a crossover with an allergic reaction with cephalosporins. So if you've got a patient that's reporting a penicillin allergy, they may have an allergy to cephalosporins as well. This one has a higher risk for C. diff, so you've got to educate your patient to look out for profuse watery diarrhea. And there is an assessment that they could do for like a true penicillin allergy, because some penicillin is like, it's a pretty safe antibiotic. So if they don't have a true allergy to it, we'd like to get that ruled out so that they can have that instead of having like a fluoroquinolone, which carries like a lot more of it's got a black box warning for tendon rupture. If your patient's not allergic to penicillin, they can use this instead of something stronger. So if your patient reports a penicillin allergy, try to educate them in that moment and say, oh, have you gotten an allergy test? You might want to talk about that with your primary care doctor. It's commonly used for strep, pneumonia, UTIs, and skin infections. Our cephalosporins, make sure there wasn't anything else that y'all need to know. Oh, with our penicillins, it's taken on empty stomach 1 to 2 hours before meals unless it causes GI upset. With our drug interactions, avoid taking it with citrus juices or acidic foods as it might reduce absorption. And that is it for our penicillins. For cephalosporins, we're looking at nephrotoxicity and ototoxicity as well as red man syndrome. Is red man syndrome an allergy? No. Is it a reason to rule out this patient receiving vancomycin? No. We just need to communicate it with our physician and see if we can pre-medicate these patients or slow down the rate that we're infusing the vancomycin. Red man syndrome is characterized by flushing, hypotension, rash, and again caused by rapid infusion. We want to infuse our vanc over at least 60 minutes, monitor our trough levels, and monitor our creatinine. We also treat C. diff with oral vanc, so we want to educate our patients on all antibiotics across the board. Take your medicine as prescribed and take the entire course of antibiotics. With our vanc, we want them to report any rashes, ringing ears, decreased urination, or diarrhea. Oh, there is something you'll need to know about cephalosporins. For cephalosporins, our patients cannot drink any alcohol while they're taking this medication. They will have it's called a disulfiram reaction, and it's going to be severe flushing, dizziness, and vomiting. So for cephalosporins, no alcohol for the duration of their treatment, and as well as 3 days after that antibiotic is finished. Same for our, for our macrolides, these are going to be our mycins. These are going to inhibit bacterial protein synthesis, and it's used for respiratory infections and atypical pneumonia. This is a med that's going to cause QT prolongation. So think about meds that might prolong our QT. Zofran, amio, a whole slew of medications. So that's something in the hospital that if they're on a macrolide, we might wanna watch that a little closer. These also cause GI upset, and we wanna avoid other QT prolonging meds with this. This also has a potential for development of C. diff. Our patients need to report if they're taking outpatient, any yellowing of the eyes because the drug is hepatotoxic, and any new palpitations. They also have to avoid excessive sunlight because this medication causes photosensitivity, and they will use sun protection. They do have the rare side effect of hearing loss, but it is typically transient. For our fluoroquinolones, this is gonna be our ciprofloxacin and our levofloxacin. These are gonna inhibit DNA replication of bacteria. It's used for UTIs, pneumonia, and GI infections. Our fluoroquinolones have a black box warning for tendon rupture, peripheral neuropathy, and CNS effects. It's contraindicated in pregnancy and in children because it carries a risk for cartilage damage. We want to teach these patients to report any tendon pain immediately and avoid taking with antacids or dairy, as well as these cause photosensitivity. These can also cause esophagitis, so they have to take the pills with a full glass of water and make sure they really get that medication all the way down their esophagus. Our tetracyclines are gonna be doxycycline. This is gonna inhibit protein synthesis. It's used for acne, Lyme disease, and respiratory infections. Our major issues will be tooth discoloration, photosensitivity, and again, esophageal irritation. So when you think about patient education for our fluoroquinolones and our tetracyclines, think about these patients need to take this medication with a full glass of water so they're avoiding esophagitis. They also wanna avoid consuming dairy products, iron supplements, and antacids. For our aminoglycosides, we've got gentamicin and tobramycin. Unfortunately for the antibiotics, you can't as much rely on the medication name to remember their class, because you noticed a bunch of them end in mycin, so it's just gonna have to be kind of memory for that. We use this for severe gram-negative infections and sepsis. It is high risk for nephrotoxicity and ototoxicity. We're going to measure a peak and a trough with these, look at their BU and creatinine, and assess for hearing changes. These are not absorbed well through the GI tract, so we're really gonna give them only IV or IM, and we can also give them as eye drops. These are our sulfonamides. These are used for UTIs, MRSA, and pneumonia. The major thing that we want to look out for this is also Stevens-Johnson syndrome, hyperkalemia, and bone marrow suppression. Our patient teaching is going to be drink a lot of fluids and report a rash immediately. We want to tell these patients to drink a lot of fluids because sulfonamides have a tendency to crystallize in the kidneys, especially in our older adults. We've got metronidazole or Flagyl. We use this for C. diff, trichomonas, and any anaerobic infections. This has the same disulfiram reaction as our cephalosporins in that these patients cannot drink any alcohol while they're taking this medication for the duration and 3 days after they finish. If they are going to have that disulfiram reaction, it is characterized by vomiting, flushing, and hypotension. Our antifungals are fluconazole or diflucan. It has a risk for liver toxicity. Amphotericin has a risk for severe nephrotoxicity and an infusion reaction. So for these, we're gonna look at our LFTs, monitor our kidney function, and pre-medicate for infusion reactions. These are our antivirals. So acyclovir is pretty commonly used. It is used for herpes virus. It carries a risk for nephrotoxicity. We've got oseltamivir for the flu. And our nursing focus is with antivirals. You really have to start this within 48 hours for it to be effective. And we want to emphasize hydration with our patients. Okay, so just a general reminder with all of our med classes. You want to stop the drug if you've got an ACE inhibitor and your patient develops angioedema. if you've got a beta blocker and your heart rate, it says less than 50, but most orders say less than 60. So if you've got a patient on a beta blocker and their heart rate is less than 60, we need to start looking at holding that med. Digoxin, if you see visual halos and bradycardia, think digoxin toxicity. The antidote is gonna be digibind. Steroids, we're looking out for black and tarry stools, as well as a whole slew. Just review that slide with the considerations with steroids. Vancomycin, you wanna look out for severe hypertension during the infusion. If that happens, you need to contact the doctor. We're also looking out for flushing, thinking red man syndrome. Aminoglycosides, look at tinnitus, fluoroquinolones with tendon pain. Sulfonamides, think about SJS. For flagyl and cephalosporins, we're not gonna have any alcohol use. And for antipsychotics, if you see a temperature of 103 and rigidity, think neuroleptic malignant syndrome. Don't scan this yet. Okay, Mr. McCarty said y'all are big fans of Jeopardy, so that's what we've got today. And we have prizes in the little Easter basket. Break into groups of 4, 3 groups of 4, however y'all would like that arranged.
Robert,